Institute of Pulmocare and Research, Kolkata. And to speak about the topic of today, that is practical approach to DPLT, we have within us our eminent speakers and chairpersons. First, I would like to take the opportunity to introduce our chairpersons to our guests. First, we have Dr. Anshuman Mukherjee, who is an eminent pulmonologist with more than 28 years of experience. He has special interest in airway diseases, DPLD, difficult TB, and lung cancer. He is the member of Indian Chest Society, and currently he is associated with AMRI Hospitals, Kolkata. Next, we have Dr. Suranjan Mukherjee, who is also an eminent pulmonologist with 26 years of overall experience and 22 years as specialist. Currently, he is associated with Sparsh Diagnostic Center, Kolkata. With this, I would like to address to our chairperson to kindly proceed over the session and introduce our eminent speakers to our guests for today's session. Over to you, sir.
Shall I start?
Dr. Mukherjee, yes, you can start.
Yes, is Dr. Anshuman Mukherjee here yet? No, I can't see him.
If Dr. Anshuman Mukherjee hasn't joined yet, you can begin with the session, sir, because you are also a chairperson, one of our chairpersons. Okay. So you can begin with the session.
Start the meeting then. Okay, first of all, good evening to everybody. Very good evening, and I would like to thank the organizer, especially Dr. P.S. Bhattacharya, for asking me to chair this session. As you all know, this is a chair on the practical management and approach to DPLD. And we have got our speakers. I would like to introduce our first speaker, Dr. Arindam Mukherjee. Now, Dr. Arindam Mukherjee, he's MD in internal medicine and DM in pulmonary and critical care medicine. And currently he's associated with IPCR and also with the Tata Medical Center. He's going to take us through this talk on logistic hindrances in managing DPLD. Over to Dr. Arindam Mukherjee.
Thank you, sir. Thank you for the kind introduction. I just want to share the screen and start the conversation. Am I audible? Hello?
Yes, sir, you are.
Yeah, thank you. Now we are starting our today's first session, which is on the logistic constraints in ILD management in India. So basically, it's a very interesting concept that we are taking India into consideration. So we'll go through the topic in the following subheadings. First, we will discuss where do we stand now. So we stand at a juncture where the first Indian registry cohort has been published from under Dr. Shetu Singh's and guidance. It's a coordinated study all over the multicentric study with the chief coordinating center at the Jaipur. And they have found that unlike other countries, we don't have IPF as the most common ILDs. We have hypersensitive pneumonitis as the most common ILD. So the scenario of ILD are a little different in our country. And it is reassuring that we have some less fibrosing diseases which are topping the list. So we have hypersensitive pneumonitis, then CTD ILD, then comes the IPF, which is 13.7%. Next, we will proceed to another study that is published after 2 years. This study is from PGI Chandigarh, which is itself a very big center of interstitial lung disease, and they have published a study after going through 803 patients, and strikingly they have got some different figures altogether. They have got that hypersensitive pneumonitis is 10.7% in comparison to 47.3% in the Indian IPF, Indian ILD registry, and sarcoidosis is much higher. It is 42.2%. There can be several reasons of this disparity. One of the reasons could be that IPGMER is that PGI-MER is a center of excellence for sarcoidosis care. So sarcoidosis patients are usually referred, and so they can have a more number of sarcoidosis. But interesting is that both IPF and non-IPF IIPs, they are relatively in the same range in both the studies. So most likely in India, we deal with less fibrosing diseases. I am not going to discuss more about epidemiology, diagnosis, etc., because we are about to discuss about the constraints. Though we have a less fibrosing disease, more steroid responsive ILD, we cannot treat ILD like our counterpart in Western world. What are the constraints? The constraints start with lack of recognition of the disease. Then comes the inadequate and incomplete workup, which we often face. And the most important, I think, is the cost of comprehensive care and lack of focused infrastructure. So under these four headings, we'll try to look after what are the problems in our ILD management in this nation. So delays recognition is a frequent thing all over the world. Delayed diagnosis as well as misdiagnosis of ILD is common. There is a uh, study published in 2016 in European Respiratory Journal, which has shown that 50% of our patients, they have a 1-year delay in diagnosis of ILD, and during this delay period, more than two-thirds are being diagnosed as obstructive airway disease and being prescribed inhalers. It is not much different from even the United States data. 2007 registry has shown that 55% of the people in the United States with ILD or rather IPF, they have 1 year waiting time before they can be diagnosed with their proper diagnosis. So this is not very uncommon from the world over figures, but this is one of the first point where we are lacking. We should try to diagnose the diseases early. Then we come to the workup. Workup of ILD has several subheadings like radiology. HSCT chest is the cornerstone of ILD diagnosis all over the world, and HSCT chest is available now most of the centers, but when we are going from urban to suburb to rural areas, HSCT chest is not available and people has to travel miles after miles to get HSCT chest done. That also hinders the diagnosis, delays the diagnosis, and also has problems with our follow-up. Then we come to the laboratory and we have that whole lots of CTD serology, which has a full group of anti-synthesis antibody, full group of ANA subclassified antibodies. The cost and the availability of the test, these are really problemsome till now. Interventional pulmonology, interference like transbronchial lung biopsy and transbronchial cryo lung biopsy, which is a newer addition. They are being done, but to a lesser extent due to the same reason that centers performing this kind of interventional pulmonology are less. They are centered in the main cities, and going outside the cities, there are very few centers, and communications issues coming to the center, cost issues are making this kind of approaches rarity in management of ILD. So that I will show you just after this slide. Then we come to the VATS or surgical lung biopsy to prove the accurate diagnosis, which is more rare to have in India now, even nowadays. Histopathology, if you don't have a biopsy, there is no question of histopathology, but till it is the gold standard, and we want to have more and more histopathology before treating our ILD patients. And last and most important nowadays is multidisciplinary discussion based diagnosis, which give a edge over all other parameters. When they are combined together, MDD give a certain edge, MDD give a certain more diagnosis in case of unclassifiable ILDs. MDD is a newer addition. MDD is being practiced in higher centers or centers which are more focused on pulmonary care, but it is till date, it is not a common practice in all over the centers, which is very much necessary. Now, what I am calling inadequate workup. Inadequate workup doesn't mean the inexperience or inadequacy from the physician. It is the lack of feasibility. Like when we have this PGI study, which has been done in Chandigarh, then we see that for the diagnosis, they have transbronchial lung biopsy done in 48.8% case. In 400, among the 401 patients, they have done 86 patients. They have done transbronchial lung biopsy in 24 patients. They have done surgical lung biopsy in 5 patients. And all some of the or other are combined in 276 patients. So most of the patients have underwent some kind of interventional pulmonology approach, and they have a altogether different diagnostic output than the this study, which is showing this multi-center registry, where before starting the registry, the clinical characteristics and imaging characteristics were defined, and the diagnosis was not made on biopsy. It was diagnosis was made only on this clinical and imaging characteristic. So there is a discrepancy. There is a difference how the diagnosis is being made. And here the MDD was not like a single center MDD. Here MDD was done at the apex center as a coordinating center. So that is the feasibility or uniform diagnostic workup is not possible throughout the country. That is a constraint for us. And when we do a study at Institute of PULMOCAN, where we have asked doctors, there was 120 participants, that which kind of investigation you can do, then you can have that lung biopsy is available in 54% people, and HSCT is available in 98% people, multidisciplinary discussion with 47% of people. So all the doctors, most of whom are pulmonologists, more than 80% are pulmonologists there, they are still not having all the opportunity of diagnosis at their hand. That is definitely a constraint for diagnosis or properly treating ILDs. Then we come to the most important part, that is the cost of care in ILD. ILD is a very costly affair. Why I say so? Let's see. This diagnostic process, it needs outpatient visits, imaging, multiple imaging, spirometry, multiple spirometry, autoimmune serology is very costly, and biopsy procedures. This much of investigation are needed before the diagnosis is made. Whereas asthma can be diagnosed with a spirometry only, or a COPD spirometry is very good to diagnose and starting treatment in COPD. But you cannot start treatment in ILD unless you get this much of results in your hand. Then you come to the post-diagnosis care. And you have a lot of comorbidities in the aging patients like cardiovascular, pulmonary hypertension, obstructive sleep apnea, lung cancer, chronic obstructive pulmonary disease, or gastroesophageal reflux. You have to diagnose them and you have to treat them. All of them add to the cost. Then the ILD care, particularly if it's a progressively fibrosing ILD, there we have this surveillance spirometry, pulmonary rehab, pharmacological therapies, which are very costly if you consider the length of therapy, smoking cessation if it's net therapy also, vaccination, oxygen cost, which is very sustainable cost for oxygen. Lung transplant is not a common option in India right now, and symptomatic management, which also requires a very costly group of drugs. And if the patient get an acute exacerbation, whether it's infective or non-infective, if we have to visit the emergency or get hospitalized, then the cost is multiplied several times. This data has been taken from this study, and I will show you another abstract presentation which has compared the cost or healthcare resource utilization cost 12-month pre and post diagnosis of ILD in RA-ILD cohorts, and you can think that inpatient admission, length of stay, outpatient visit, emergency visit, urgent care visit, pharma prescriptions, inpatient cost, outpatient cost, emergency cost, urgent care cost, pharmacy cost, all are significantly higher once a RA patient has diagnosed with ILD than before ILD. And they have also done an analysis. It is shown between patients who are having RA with ILD and between patients who are not having ILD, only RA. And again, you say the same parameters, the cost is much higher if you have a ILD associated with RA. And this is from this abstract by Joe et al. So we can definitely see diagnosis of ILD in a pre-existing CTD or on a patient who has no prior diagnosis has a certain burden of cost on the patient. And for a country like us, this cost is sometimes unsurmountable and patients are become non-compliant, which is a huge problem for our logistics. And when we do the study, we are referring from the IPCA. What they had shown that financial capacity of the patient is the main constant. These numbers 4.8, 3.38, they're the mean of a scale between 1 to 10, where we have tried to identify which is the main constraint to the physician who is treating the patient. And overall, among the 120 participating physicians, we found that financial capacity of the patient they feel the main constraint, and they scored it much higher at 4.8. Access to investigation, the constant level is 3.38. Time constant on part of the patient is 2.6. Distance of doctor is 2.85. Distance of the hospital or investigation center from the residence of the patient is 3.35. And lack of available attendant to support to visit a doctor or hospital is 2.98. Hazard in getting the appointment is 1.48. So these are the constraints that we have found in our study. Now we come to this focused infrastructure. Actually, what do we mean by a focused infrastructure? We mean this comprehensive care of ILD, which has multiple aspects. Like you have to control the symptoms, dyspnea, fatigue, cough, anxiety, and depression. For this, you need rehabilitation, you need relaxation sessions, you need much more communication. Then comes the therapy. It has antifibrotic therapies, immunomodulatory therapies, and ongoing trials where new drugs are being tried. You need the supportive measures even at home that include supplemental oxygen, pulmonary rehab, education, and psychological support. And at the same time, the patient should be counseled about the prognosis also. Timely end of life conversation, treatment limitation understanding, and preferred place of death to be identified. This is definitely a paper from the Western countries. But this kind of a care we also want to provide to our patients. So I have quoted this. And when it comes to us, when it comes to US, they have done a modified Delphi survey for essential important things for an ILD clinic and what they want to have in their ILD clinic. That is a utopian idea maybe for an Indian subcontinent doctor, but till we can have a look what they want. They want something as essential, something as preferred. Among essential, they want the physicians to have expertise in ILD. At least 2 or more pulmonologists should work in a single ILD clinic. There should be nurses, and it should be close supervision by advanced practice providers. Then there should be close supervision by physicians. Research coordinator should be there, as all the patient should be in some kind of trials. And some things is good to have, like dedicated ILD nurse, clinical coordinators, and fellows trainees if possible. These are the manning of the center. Infrastructure, they need the ILD clinic, how many patients they see, easy access to clinic, triage and rerouting referrals to ILD clinics from general pulmonary clinic, triaging of ILD patient before new patient visit in order to avoid multiple visits. Maximum time from referral to a new appointment should be less than 2 months for a standard new patient visit. And they want that time should be reduced to 7 to 10 days. Patient management strategy is providing a mix of primary management, collaborative, shared care, and consultative management. And they want to have all the histories. Then they have the pulmonary rehabilitation center should be within 30 to 60 minutes drive away from the ILD clinic. And general rheumatology, thoracic radiology, pulmonary pathology, thoracic surgery, pulmonary hypertension care, cardiology, and palliative care should be available as an ancillary service at the same clinic. Pulmonary functions testing can be done on the same day appointment, and there should be a dedicated HSCT protocol. HSCT should be available on the same day, preferably, or on the next day. And there should be research opportunities like participation in research, participation in clinical trials, participation in patient registries. Patient education should be available, like patient education is delivered by physicians. Patient education is delivered by nurses or ILD clinic participants. And the last one is multidisciplinary conference. They want to have a different disciplinary conference as frequently as possible. It will last at least once every 2 weeks is what they want to have. And it should be staffed by a pulmonologist, radiologist, and pathologist. And discussing the following patient and multidisciplinary conference, complex cases with diagnosis or therapeutic dilemma, patient who have already had surgical lung biopsy, patient whom a surgical lung biopsy is being considered. So this is the Delphi survey over the Pulmonary Fibrosis Federation of US, who has a clinical network centers, and their directors has participated in this Delphi survey, and they have come out with this kind of setup, what they want for their ILD clinics.
2 more minutes.
Thank you, sir. Now we come to the last slide, where we are heading to. We start from where we stand, and now we are ending with where we are heading to. And I think I see something positive. Pandemic has increased the awareness for lung disease as well as HSCT, which I think is good. And CTSI scoring, which is being done, scoring like that in non-pandemic era can make interpretation more algorithmic for the HRCT, which is more objective. ILD treatment going to be decided on CT features. My next speaker is going to be discussing on that biopsy may not be required in future. Teleconsultation is getting popularity. So virtual clinic in future can help us doing multidisciplinary discussion as well as patient need-based follow-up, which are, I think, the near future for the ILD management in our country. Thank you, sir.
Thank you very much, Dr. Mukherjee. It was a very nice talk. Really, I mean, there are lots of constraints in ILD management in India. I mean, just to add, I would also... I would also like to add points. Can we Hello, can you hear me?
Yes, you're audible. Shuranjan, continue.
I think there are three issues also we need to be aware about. Is number one is you have mentioned about valve fluid. There is a valve fluid analysis, the expertise, whether we really have the expertise in analyzing the valve fluid. Secondly,
Shuranjan, unmute yourself. Shuranjan, unmute yourself.
Right. Okay, can you hear me? Yeah. Now, as I said, about the valve fluid analysis, expert sort of pathologist or cytologist to analyze the valve fluid, just leaving aside the importance of transfer of the fluid to the lab. Secondly, I was talking about the presence of expert thoracic pathologists. We do have sort of dark of trained thoracic pathologists. Thirdly, it's very important. There is, I mean, we have diagnosed that in our registry, we have shown that about 47% have hypersensitivity pneumonitis. But the serology sort of profile we do in our country, whether they are calibrated for the actual antigens that's prevalent in India, we do some, I mean, serology particularly for pigeons, but the other fungi and the other antigens, whether we don't have that sort of kit available readily.
I believe, Shuranjan, the problem with hypersensitivity pneumonitis panel is we don't have an identification of the right antigens which trigger the HP syndrome in our country. So that is another impediment probably we would face in diagnosing HP.
Anyway, I mean, we have to carry on with that. Now, for the next talk, unfortunately, Dr. Parthasarathi Bhattacharya has got some technical glitch in his computer. So he just informed me that he will join us as soon as that's fixed. In the meantime, I would like to invite Dr. Sujit Rajan, who is going to take us through the to his talk on follow-up of patients with DPLD. Now, Dr. Sujit Rajan is an MD and DNB and DTRD. He's a consultant respiratory physician on interstitial lung diseases, and he runs an ILD clinic at Bombay Hospital Institute of Medical Sciences, and he's also associated with Bhatia Hospital, Mumbai. So I would over to Dr. Sujit Ranjan. Dr. Ranjan, are you there? I can't see him, actually. Has Dr. Ranjan joined?
I think Shuranjan.
Yeah, I can't see him.
Hello?
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 Actually, Dr. Ranjan is not with us now. Can you please, I think Dr. Abhyankar is available if it's
Okay.
possible for him to give his talk.
No, can you communicate with Nitin, please? If he is willing to come forward, then
Is he here?
Nitin, are you there? Hello, Nitin, are you there?
Abhyankar?
Yeah.
Okay.
Yeah.
Okay.
I'm there.
Very good evening. Right. Let's move on to the fourth topic on this session. Dr. Nitin Abhyankar. He's an MBBS and MD in pulmonary medicine with more than 20 years of experience. And he's currently working as a consultant pulmonologist in Dinanath Mangeshkar Hospital. And his areas of interest are asthma, lung cancer, pulmonary hypertension, and pulmonary fibrosis. He's going to take us through his talk on on pulmonary DPLD, present and future. Over to Dr. Abhyankar.
I'm just starting to share the screen, so just to check that I'm on. Is my screen visible?
Yes, your screen is visible, Nitin. We can see you.
Shuman, you will take over for the next two talks. I think Dr. Bhattacharya is here as well.
Okay.
Dr. Rajan is
Ranjan, how can we continue without you? Please.
I'm here.
So I think now it is going to be back to the future, so that because I think my talk is preponed, so I'll take you to the future a little bit, and then you'll go back to the future. I mean, in the sense of the other talks. Okay. So I think the crux of the matter in the what will happen in future in the ILD management is the diagnosis is going to change dramatically over the next decade or so. That is what is expected. And there is an increasing trend all over the world to subject lesser number of patients to lung biopsy. In fact, I work in a unit where we do medical thoracoscopic lung biopsies for interstitial lung disease. We do transbronchial lung biopsies. We also do some cryobiopsies of late. And hello. And we are a biopsy-centric kind of a unit. And what we have seen over the last 2 or 3 years is that our numbers are actually going down, and correctly so, because we are requiring it in lesser number of patients. So an invasive procedure is something which is not suitable for a large number of them. And the single change which may make this happen is possibly the molecular evaluation, which will become increasingly important. In fact, we have already are aware that TOLIP DSPs, the MUC5Bs, the TERTs and whatnot. I mean, the kind of genetics that is going to be there, and the genetics will be deciding, whether they will have an impact, and certain mutations are associated with certain interstitial lung diseases, particularly UIP, IPF is the best studied in this particular territory. And if you really look at the familial IPF, then in that case, the genetics are going to become important. I'll touch upon this and then come back to it again. At this point in time, the genetic testing is currently not recommended for all interstitial lung diseases. It is only when you have a certain family history, then you start moving on that particular normal on that pathway, and then only in certain situations you will be looking at, say, telomere length shortening, and those kind of studies will be relevant. So at this point in time, I'm not too sure whether we are exposing a large number of our patients to genetic studies, and it will remain that way. But I think this is the way we are probably going to move in the future, in the terms of the people who have a family history of idiopathic interstitial pneumonias, and that will become more and more relevant. Plus the fact that certain subsets of people, for example, people who developed hypersensitivity pneumonia, some of them only develop a UIP pattern, or for example, some people with say CTD ILD, only some of them develop UIP pattern. Only some of them will develop organizing pneumonia pattern. So then again, the genetic testing may become relevant in future for those subsets of patients who are actually genetically prone to developing a UIP pattern if a correct insult is there in the background. And that correct insult could be not necessarily what we are defining as UIP, where we don't know what the context is. It could be one with an identified inciting event also, like in CTD-LD or like in hypersensitivity pneumonia. But you could eventually predict that, okay, this person is more susceptible to getting into a UIP, and therefore I will be probably watching him more carefully, or I may be thinking of antifibrotics a little more earlier than not. So that is another thing which is interesting. I'm sure all of us have heard of, say, plasma surfactant protein D or MMPZ, metalloprotease 7, and we also understand that, for example, SPD, MMP7 or osteopatin, they enhance diagnostic accuracy in patients with IPF compared to those with non-IPF ILD. So there are some markers for, so genetics is one component, the biomarkers is the another one, and I think that is where we may be heading towards, if that is from some kind of a lung tissue, and I'll come to that in the next few slides. But if you really look at it, this is where it is, the ball was set rolling even 5 years ago, and it is there is an increasing data which was getting accumulated. Very frankly, this lecture I have taken, say, about a year back in the beginning of 2020, and after that the COVID has probably completely put a stop to all kind of consideration. So last 1 year there has not been much new knowledge which has come in, because we are struggling with the COVID pandemic as such all over the world, and therefore most of the studies are on hold, or the recruitment has got tremendously curtailed. So there is no new data which is emerging. But this data which has been there with us also will help us into peeping into the future. And biomarkers is one of the future approaches which will give us a diagnostic accuracy, and B, also it will help us in prognostication in some situations. So this is another example where this is UIP patients with ILD, and assessment of machine learning approach with higher dimension of transcriptional data. So that is again, machine learning approach is another entity which is going to walk in over a period of time, and then certain signals would be appropriated into with the kind of biomarkers that you have at your disposal. And the other interesting feature which comes from this particular study, which talks about it could be feasible with using a transbronchial lung biopsy sample, so a relatively less invasive methodology. And then they have studied that, where it could be coming from, upper, middle, or lower, and then what kind of a pattern that will emerge. And then you are looking at not so bad sensitivity of around 0.6 and a specificity of around 0.86. So it is not all that bad. So if you look, of course, these are small databases. This is not something which is a part of the guideline, but this is where we could be going to. And this was the in this particular study, they said that if you have 5 or more transbronchial lung biopsies, they seem to be yielding an excellent specificity of around 90%. And a sensitivity which is close to around 70%. So if you look at the biomarkers coming from the transbronchial lung biopsies, that would be a very, very good way of looking at the patterns. I mean, even without getting a tissue, a large amount of tissue, with a small tissue, looking at the biomarkers and combining that data put together, you can very well differentiate between a UIP and a non-UIP procedure with a great deal of specificity and a certain amount of sensitivity also. So if you really look at it from the point of view of what would happen, is that beyond MDD, currently we start suspecting it. I'm sure we have gone through this particular algorithm as to where are we really looking at it. Are we really looking at any other? Are we looking at a possible IPF? Where would we consider a surgical lung biopsy? Where would be or for that matter, a multidisciplinary discussion would be there right from the word go. You do a chest HRCT, the radiologist comes into the play, the pathologist insight into where to biopsy, what to biopsy would be coming into the play. So MDD is always there. And then there would be certain molecular signatures which would get incorporated, both for a diagnostic certainty and also for pathway specific therapies. For example, if I have something which is telling me that this is going to respond to antifibrotics in a very convincing way, I would go antifibrotic way. If something tells me that, look, this is something where immunosuppression or a steroidal approach is the correct approach, then I'm going to go there. So if you really look at it, I'm sure today we had some amount of discussion on this, and we will probably have it in the next lectures, that for the all practical purposes we are now dividing
Are you there?
just two spectrums of it, whether it is a chronic program, IPF or not is another story and it scenario. But even if have that, you just are able to sort kind of a variety. You can make much better becomes a player even today. Signatures which are coming from either blood samples or from the transbronchial samples. So that would be the way that is. So we'll try and go a little deeper into what is available on the biomarkers a little bit, just 2 slides or so. The development of biomarkers to personalized therapy is an innovation that researchers say can guide diagnostic, therapeutic, and prognostic approaches in managing IPF. As the current standard for diagnostic IPF is performing a lung biopsy, which is not possible in all situations because of the significant risk. And I'm sure most of us do come across this problem, that many a times the patient are just not fit enough to undergo a surgical lung biopsy at all. And therefore, in those situations, even otherwise, whenever I have a choice of making a confident diagnosis without a biopsy, I would resort to a non-invasive methodology any day. So developing biomarkers to assist in accurately diagnosing the disease would be crucial for administering timely and effective therapy also. For example, KL6, which is Krebs, Wand, and Lungen, or various leukocytes or circulating innate immune cells have been all shown to discriminate IPF from the healthy individuals. KL6 additionally shows potential for discriminating ILD from other benign lung diseases also, for example, bronchiectasis and so on and so forth. SPD from a Japanese retrospective analysis, surfactant protein D exhibited prognostic effects in an IPF cohort receiving pirfenidone. This result showed a potential therapeutic biomarker in pipeline for IPF treatment, but at that time the data was not good enough, and therefore we are still looking for a little better biomarker at this point in time. So now we'll move on to the therapy part of it, and I'm sure I'm not going to go into the nintedanib versus pirfenidone argument here at all, because I think that will come into the current therapy. So I'll try and stick to what is not likely to be covered by the other speakers. So please don't mind me not talking about the present part of it as much as the possible future. So why do we need more therapeutic options beyond the 2 antifibrotics that we have? None of these agents which are currently available, the treatment are curative. Obviously, they are not curative. They are just, the therapeutic response is obtained only in a subset of patients. So it doesn't work in all, and the survival is even poor even in those who respond. Not necessarily all of them are tolerating the drugs that you're giving. Pirfenidone is a notorious example for that. So that is another limiting factor. In addition, these agents all carry significant side effects and toxicity. For example, the skin reactions which come with pirfenidone, the loose motions which are associated with nintedanib, those are the limiting factors for the currently available therapies. So there are a huge number of molecules which are being studied, and number of phase 2, phase 3 trials which are being studied in something like 40 IPF open label IPF intervention studies are going on at this point in time in various stages. Some of them are actually finished enrollment, some of them are, and I'll touch upon anti-reflux surgery and some of those things. But a few names which I can throw at this point in time. One of them is, of course, pentraxin 2, which is serum amyloid P, which inhibits the monocyte differentiation into a pro-fibrotic fibrocytes or pro-inflammatory macrophages, and also inhibits the production of transforming growth factor TGF beta 1, which is a potent regulator for connective tissue synthesis. This is one of the mechanisms which is proposed for pirfenidone action also, though we understand it relatively poorly how exactly pirfenidone acts. But pentraxin 2 is possibly acting on the TGF beta also, just as it's acting on the monocyte differentiation as another target for it. And these are two trials, one which showed that the pentraxin 2 concentration are lower in plasma for patients with IPF than with normal subjects. And in a randomized trial in patients with IPF who were randomly assigned to recombinant human pentraxin 2, 10 milligram per kg versus placebo intravenously for over 24 weeks. The data, though it is said to be preliminary, and 2018 showed a slower decline in the lung functions in the patients receiving pentraxin 2 than placebo. The most common adverse events were cough and fatigue. So this is something which may come in. We are not too sure at this point in time, but I think because last 1 year has been a bit of a black hole as regards the medical research in even ILD goes for many diseases which go, and we have a new entity of COVID-related lung fibrosis, which is another big black hole at this point in time, which we are trying to struggle with. So that's another one. The other one, which is the GPLG 1690, which is an autotaxin inhibitor. The dose is 600 milligrams once daily for 12 weeks. This is one study again, small study. Primary outcomes were safety, tolerability, pharmacokinetics, and pharmacodynamics. Spirometry was used as a secondary outcome, so it was not ready for the real-time kind of a prime time kind of a usage at this point in time. And it is comparable to placebo, the side effects. So there was no acute exacerbations or deaths during the study. But of course, we are still waiting for a well-powered randomized study which will determine the efficacy. In the true sense, the efficacy is not studied in this small trial actually. So that's another one. I'm sure most of you have now surely started entertaining the idea of using pirfenidone and nintedanib. And there is some data in the real world as well as some data coming from some studies. This is Flaherty in 2018, and this could be done even today in Indian scenario with the nintedanib price becoming realistic. So a pirfenidone used between, say, the standard dose of 1800 to 2400 and 200 to 300 milligram of nintedanib has been used in patients with IPF. And what they were saying at that point in time was just that it was tolerated by majority of the patients with the IPF associated with similar pattern of treatment emergent adverse effects of the either treatment alone. So that means all it did was that whatever side effects were there, you will also get an upper GI problem with pirfenidone and a lower GI problem with nintedanib, and they will be added, but you are not going to get extreme side effects when you use them in combination. So the combination use is possibility in the near future, particularly because the price has now become realistic in the Indian scenario. FG3019, which is pamrevlumab, one of the MABs in a prospective study.
2 minutes, Dr. Abhankar, huh?
Okay. Yes, 2 minutes. Yes, I'll be winding because this is just nearly the end of it. So specifically designed to target connective tissue growth factor, has an acceptable safety profile, and none of the patient-related outcomes measures showed any benefit. So this is something which is a negative study. So this particular molecule is unlikely to come into our situation. There is some data about cytokines and growth factors, and I'm not going to go into the depth of this because the data is so limited at this point in time that we are not realistically looking at this. But I think the last 2 slides mostly for my presentation, a systematic review and meta-analysis of 8 observational studies suggests that pharmacological treatment of GER is associated with IPF-related mortality, but not overall mortality. So there seems to be an impact of treating the GER. This is Dr. Raghu's very favorite topic, and the RAP IPF trial, which I'm going to show in the next slide. The effectiveness of anti-acid therapy remains a little uncertain, and controlled clinical trials of acid reflux in IPF are needed. And therefore, WRAP IPF is another trial which is recently concluded. It's about a year and a half that it was concluded. It's a non-blinded trial. 29 patients with IPF randomly assigned to receive laparoscopic anti-reflux surgery and 29 to receive medical care without surgery. They were both either nintedanib or pirfenidone were allowed. the surgery group had numerically fewer secondary outcome events. For example, acute exacerbations were less, respiratory-related hospitalizations and death were less in numbers, but they did not reach a statistically significant save. Therefore, a larger, well-powered randomized trial is still needed to efficacy of anti-reflux surgery in this population. And this is something which is interesting because some of these patients, and in fact, Dr. Raghu has been pursuing this particular entity for a very long time, and we may be looking at this particular as because it's an unidentified cause. Exactly, we don't know exactly the etiology and whether the reflux is contributing in a large way in some of these patients, maybe a small subset of patients. It's worth exploring. So it is worth looking at that. And then there's a little data on omeprazole 20 milligram twice daily for 3 months and the cough frequency monitoring. And the cough frequency seems to be lower when cough is a distressing feature of some of the IPF patients, and it seems to be around 40% lower. So this is something which you could use as compared to the placebo. So it could be something which you could use in future. Once again, not something ready for prime time, but it could be used in select patients where the cough is a distressing feature. And with that, I would not be badly placed in making one last comment about the lung transplantation. I'm sure some of them are going to talk about it. We have witnessed 2 lung transplants in this country, even in the COVID scenario. So COVID-related lung damage also has undergone a lung transplantation. At this point in time, the lung transplantation is actually in a very, very small scale that has been appreciated, but there is an increasing usage of this in the therapeutic armamentarium. And I think a substantial number of young people who are having a single organ failure and ILDs of various etiologies, particularly hypersensitivity pneumonia, often lands up here. RA-related ILD or CTD-related ILD often lands in this kind of a zone. So not necessarily for UIP IPF, which is a scenario with elderly individuals, but people who are early into it and dying prematurely, a lung transplantation can be a savior. It has been documented even in the COVID scenario, so it's not completely off at this point in time. And it's something which we will probably look at with great interest in the near future. With that, thank you very much for your patient listening.
Thank you very much, Dr. Abhankar. It was a very comprehensive talk. Now, any questions from the audience or Dr. Anshuman Mukherjee, do you have any question?
Not really. Nitin, as usual, has been very, very lucid and very frank with his presentation. So I think so far as the therapeutics of IPF or the whole ILD armamentarium, ILD plus rainbow, we are still left with only antifibrotics and steroids and probably nothing else. And we are probably not in the near future. We still don't have a candidate drug which we can confidently say that will change the scenario of management of any of these ILDs. So I think Sujit is here. So hi Sujit, how are you?
Hi Anshuman. I'm sorry for the delay. There was a glitch at a gynac meeting just where I was talking about sleep apnea that I got stuck in. They had a bad web system, unlike Partha's system, which seems to be working beautifully.
So welcome to Suranjan. I think you have all the details of Sujit's presentation.
Okay, you can take over, Anshuman.
No, I don't have the Sujit's here.
Okay.
Can you see the slide, Suranjan?
Yes, we can.
Yes.
Just a second. I will go to.
Sir,
Right.
do you want to give a brief introduction of Dr. Suranjan?
Right. Okay.
Dr. Sujit. Suranjan is here with us, and Sujit needs no.
All right. Okay. Okay.
Before starting off with our.
I mean, Sujit doesn't need any introduction anyway. Just make the audience aware. He's MD and DNB and DETRO, and he's a consultant respiratory physician in interstitial lung diseases. He runs an ILD clinic at the Bombay Hospital Institute of Medical Sciences, and he's also associated with the Bhatia Hospital, Mumbai, India. Over to Sujit for your enlighten us with your talk.
Can everyone see the first slide?
Yes, Sujit, you're visible.
Yeah. First slide is there. Okay. So I'm just trying to increase the slide size. We're in presentation mode. So thanks, Partha, and I wish I could be physically at this meeting. Unfortunately, we are just aspiring for physical meetings right now, and we have to work with the virtual route. So I thought I'll try and make it as practical as possible. At the same time, also focus a bit on what research is telling us about monitoring patients. These were the 5 parameters on which I want respiratory physicians and general physicians also managing ILD to look at monitoring symptoms and diagnosis. That itself is part of monitoring, because if you don't have a secure diagnosis, you're not going to move forward. Then you have your objective parameters, and they are very important moving forward. And then, of course, your treatment, as Nitin beautifully explained. The parts which I will fill in there, I think, are course corrections that we need to do when we are monitoring our patients, in ADR management, which is all part of monitoring. Communication, which is a topic I'm passionate about, is very relevant here. And of course, dealing with the very sick patient. So all this would encompass monitoring of an ILD patient. Remember one thing, that about 6 years ago, Vincent Cotton from France suggested that it took about 1 year from the time a patient had symptoms of IPF to be diagnosed with IPF. I think that is really sad in terms of clinical medicine, that a disease that has a survival of 3 to 5 years post-diagnosis takes 1 year to just diagnose. And I think there are important questions, and because the topic was ILD, there are important questions that we need to ask patients, not just about IPF, but about other ILDs in the history that we miss. And that is the drug history that I can tell you that I have missed in the past, and that I never now fail to miss in my history. The rheumatological history, the family history of ILD, especially when you have short telomere syndrome, which we know is now a common cause of familial IPF. So asking for a history of early graying of the hair, the smoking history, and the HIV status, which completely changes the diagnosis of an ILD on a CT scan. So an HIV positive status, diffuse lung disease, the differentials just change completely. So it's important to either suspect or look at all these, the pack years of smoking. We know we have smoking-related interstitial fibrosis. None of these should be missed in the history. When it comes to imaging, we know that you cannot monitor ILDs on plain chest films, and I cannot underemphasize this. I think we all know this, but this message sometimes needs to go across to some physicians who are still reluctant to send patients for too many CT scans. ILD cannot be monitored on plain film. It can be, you can look for an acute exacerbation, maybe a pneumonia, that also if it's a gross pneumonia, but otherwise you're going to have problems there. So even acute exacerbations can be pulmonary embolism. You're never going to pick that up on a plain film. And so good quality CT imaging is absolutely essential in ILD monitoring. And the baseline CT has to be good. And if there's one message I have to give out of practicing a fair amount of ILD, so we see about, before the lockdown, we were seeing about at least 6 ILD patients a day in clinic. So out of the 17 or 18 patients I would see at the max in clinic every day between 2 hospitals, 6 to 7 would be ILD. And that's why I enjoy treating it. But if there's one message I have to give to respiratory physicians is get that baseline CT correct. It's essential. You can diagnose without biopsy on a good quality scan. If you have to do a biopsy, you get the best sites, your treatment decisions, follow-up imaging, so much depends on the baseline. So if you give a good CT radiologist a well done CT today, but the last 2 scans have been bad, you're really in a bad situation because you won't have good longitudinal data. And of course, fibrosis scoring, which I'll spend a little time on. So what do you need from your CT radiologist when you monitor these patients? Where at outset, thin section, tell him you need thin section. Definitely less than 2 millimeters, at intervals less than 2 centimeters. Volume images, very, very important. Inspiratory breath hold, critical.
So, Sujit, sorry for interrupting. I think your slides are not visible. You have to share your screen again.
The slides are not visible. 1 second.
No.
Just a second. Just now they went invisible, or
no.
1 second. Can you see the slides?
Yes, now we can see it.
Yeah. Okay. So, yeah, is this seen now?
Yeah, perfect.
So none of the slides were seen before this?
No. They went off. They went off screen actually.
Okay, all right. So I'll just go back to those slides. History that's important. And I think, yeah, we discussed the rest of it. So, yeah, good quality CT, and the baseline CT is important. And what do you need from your CT radiologist is inspiratory breath hold. This is very important. So when you send even your COVID patient for a CT scan, just ensure he can hold his breath for at least a few seconds. You'll get good images. You don't have to worry about some long inspiratory breath hold. It takes a few seconds, half a minute to do a good ILD CT, literally half a minute to 45 seconds. So inspiratory breath hold is critical. If you need expiratory images, which in many patients you do need, that's a little more radiation, but it's worth it sometimes when you're looking for mosaic attenuation and air trapping. Don't give contrast. If you're doing a CTPA, first do a good plain scan, inspiratory breath hold, then do the CTPA. So when you write ILD protocol, please remember to ensure your CT radiologist does all this. And coronal and sagittal reformatted images are very important. So actually, if you talk to your CT radiologist, just tell him, just do this for me. Because tomorrow, if I need a second opinion from any respiratory physician, I've got the best CT available or the best imaging already available. Otherwise, the whole exercise has to be repeated. And coronal and sagittal images are so important because when you look at tractional bronchiectasis, you can actually see that airway going to the periphery on a coronal image. And in a sagittal image, you can see fissural nodules. You can see that fissure beautifully, and you can see fissural nodularity in sarcoid beautifully. So this is why you need these kind of images. What's new in scans is scoring, of course. And scoring, we have the luxury of a CALIPER system with our CT radiologists, and I would encourage you to push your CT radiologist to get it done. A volume inspiratory scan. What do you need for CALIPER? This is all you need. And this is sent to an IMBIO workstation for processing, and the software analyzes the image. So in a few hours, you have a score. And what's important here is that an ILD fibrosis score, we know more than 20%, has a worse outcome than those with a fibrosis score less than 20%. And a pulmonary vessel related score of more than 5% has a worse outcome than those who have less than 5%. So these are two scores you get out of CALIPER, and they are very important when it comes. As you know, where is it important to know the scores? Example I'll give you is scleroderma. Scleroderma, if you know the fibrosis score, the more the fibrosis score, the worse the outcome. So it is so important to get these scores. And we know in systemic sclerosis that even a slight fibrosis is associated with a worse outcome than no fibrosis. So ILD fibrosis scores are going to become more and more important. And I would not like to compare this to what we are seeing on CT scans reported today in COVID. That is often complete rubbish. What we see, these percentages of lung involvement and some CORAD scores, which are very often subjective and not reproducible and give a false sense of worry to both the physician and the patient. So we know that post-COVID ILD in inverted commas is not actually a lung fibrosis because a lot of those reticular opacities disappear. And so to really quantify it, you need longitudinal imaging to say what is permanent and what is reversible. So give these patients time to improve. If you give an antifibrotic drug, fair enough, but at least examine their scans longitudinally. PVRS is the best predictor of survival and FVC decline, better than even CPI and GAP, the composite physiological index and GAP. So a PVRS score, if you get a PVRS score of 4.4, it's supposed to identify those who would benefit most with an antifibrotic and can actually, if you do a clinical trial on an antifibrotic drug, reduce your sample size by almost 25%. So great way to move ahead. And it's called the pulmonary vessel related score. It was earlier called pulmonary vessel volume. And it's a computer algorithm that extracts the pulmonary vessels from the hilum to the periphery. It has no visual correlate and is expressed as a percentage of lung volume. So these are going to be important scores that we are going to be working with in the future. Coming to lung function and diagnosis, to me, spirometry is delaying ILD diagnosis. And I know I'm being a bit provocative here, but I can tell you that a normal spirometry actually is going to give you a false sense of confidence or tell a physician that, okay, maybe nothing is really wrong. And so we really need PFTs to monitor. And though FVC is considered the gold standard and the primary endpoint in most trials, which is total lung capacity minus RV and gives you the functionality of the lung, we also need to know how diseased is the lung. And for that, FVC we know can be normal with significant disease. You need a DLCO to understand the function of the interstitium. And so when I tell patients why they need a spirometry with DLCO, it is explaining to them that the only one test we have to assess the function of your interstitium is the DLCO. And so for primers and those who don't have access to DLCO on this webinar, just understand that this assesses the degree of oxygen diffusion. Normal DLCOs in all of us who have normal functioning interstitium should be more than 80%. Please remember, even 75% is an abnormal DLCO. It's already mildly reduced, and less than 35 is severely reduced. And sometimes you need to monitor DLCOs. We have seen sarcoid patients who have had 98% DLCO, and then over a period of time, you see that going to 93, 82. So just because they're over 80 doesn't mean they're normal, they're declining. So DLCO baseline is extremely important. Basically, it measures carbon monoxide, we know combines with hemoglobin 210 times more than oxygen. And therefore, it's expressed as ml of CO per minute per mmHg, and the normal value is 25. So why is it important? Because at presentation, it can predict survival. A DLCO below 35% at presentation predicts survival. Likewise, a change in DLCO in 1 year predicts survival. So those patients who improved DLCO in 1 year actually had better survival than those who dropped in 1 year. If you don't have access to DLCO, get a desaturation check on 6-minute walk, which I think now the pulse oximeter has become so ubiquitous that it's there in everyone's house now. So a fall in oxygen saturation less than 88% is a sign of a significantly reduced DLCO and associated with higher mortality, whether it's IPF or NSIP. Now, why do we need these lung functions? Because the GAP model, as was beautifully described, helps you to prognosticate. And these are the 3 measures you use, and DLCO figures. The other measures are, of course, very easily available, even with spirometry, but the DLCO adds to your prognostication. So when you add up those points, you will notice that the risk of death goes up with the number of points as the number of points increase. And this is a good way to actually prognosticate. The future is going to be functional respiratory imaging, not yet available in India, looking at specific airway volume. And this is very interesting. The Galapagos is a company which is doing a trial on an antifibrotic drug. And they have realized that IPF patients have smaller lung lobes, larger airway diameters, traction bronchiectasis as we know, and smaller airway resistance. So they have actually shown that. And in IPF, the alveolar tissue is stiff because of fibrosis, causing a redistribution of the intrapulmonary pressure and causing dilatation of the larger airways. So this product of Galapagos actually stabilized lung function and showed differences, significant differences in placebo, excuse me, in specific airway volume, as well as in specific airway resistance. So the future is going to be functional respiratory imaging, but I don't want to go into that. It's not yet available in India. And these were some great images that they showed out of that study. Finally, coming to treatment. We've used corticosteroids till 2002 when Selman showed that this disease is a non-inflammatory fibroproliferative disorder. Despite Selman publishing this phenomenal research in 2002, till 2010-12, people were still using steroids. And I think the reason people were using steroids is because there were no great trials. There was the only treatment available was then, and transplant was the only treatment available, as Nitin rightly said at that time. And so corticosteroids continued to be used till we had the first IPF guidelines in 2010. Then you had these phase 3 studies which compared ascending pulses, which really changed the way we manage IPF. I'm going to talk about monitoring these drugs. And when we talk about that, we're looking at patients on pirfenidone. GI adverse effects are the worst side effects we know. Divide the dose if you can. Take it with food. It reduces the Cmax by 50%. And sometimes I even split the dose. So even though we have a 600 mg tablet, we would give 200 mg 3 times, 3 tablets after meals, because your Cmax reduces, the patient has less gastritis. So try doing that every 20 minutes after each meal. So split the 3 doses, delay the morning dose if you can, and titrate upwards slowly. So pirfenidone GI side effects, skin adverse effects, avoid midday suns and late, and you have to monitor for these. If you don't talk to your patient about these side effects, the patient is going to land up with another respiratory physician complaining about them and counseled about them. Staying indoors for a short time after taking the drug helps. UVA rays can penetrate cloud cover, clothing, and glass. So just staying indoors doesn't mean you're not going to get a pirfenidone photosensitivity rash. Wear thin gloves for driving, hats and long sleeve shirts, and sunscreen use is important. Reapplication SPF value of at least 30, and not all sunscreens are the same. One with high UVB and UVA protection are what is recommended. Nintedanib, now much more accessible to us, dyspepsia and nausea. Prokinetics, ondansetron can be used. Diarrhea, we can give them loperamide, maximum 2 to 4 milligrams. Add codeine if it's really bad. And consider a dose reduction. Remember in the trials, those 60% of patients had diarrhea in both the INBUILD and the IMPULSES studies, that is the studies on IPF and PF-ILD. It only about 10 to 15%, or probably less than that. I think less than 10% of the patients had to go off the study because of the diarrhea. So it is manageable. Cardiac adverse effects are more concerning, but there's more and more data coming out that nintedanib is safe in patients with cardiac disease. Acute coronary syndrome, when you've got to give blood thinners, there's a risk-benefit analysis. Arrhythmias, prolonged QTC is not being reported, and valvular heart disease, no concerns, except if you're going to give them oral anticoagulants. Interesting data showing now that even patients on oral anticoagulants, especially with COVID, with severe COVID, have been tolerating nintedanib without bleeding complications. So more to hear in that space.
2 more minutes, Sujit. Huh?
Sure. I'm almost through. If there's deterioration, can you combine drugs? Well, I think 2 studies, pirfenidone with NAC, showed you shouldn't combine these 2, possibility of a harmful effect. And with nintedanib, we have a 12-week study that has shown that you can use these 2 drugs together. How about 30% had to discontinue pirfenidone, which was the discontinuation rate in the clinical trials itself. So this data, I think, should come from India, where these drugs are easily available. We can co-prescribe them in patients who are declining, and we can do studies. So the future, that is next year onwards, I think we're going to talk about steroids and in monitoring MMF, azacyclo, and rituximab in CTD, ILD, chronic HP, pirfenidone, nintedanib in PF, ILD, and IPF, and always ask about symptoms because the patient actually comes to the chest physician with symptoms. He's not bothered about lung function half the time. He's bothered about how breathless he is. And that's where oxygen, rehab, exercise capacity, and palliative care are going to play a role. Also monitor comorbidity management and the conversation you have had with him for transplant. And finally, of course, communication, which I cannot underemphasize. I always say, draw a simple diagram to explain to the patient why you're giving him an immunosuppressant drug to hopefully gain some vital capacity, and why you're giving the patient an anti-fibrotic drug to slow the progress of the fibrosis. If you don't communicate this well, you're going to have a patient who goes back, monitored by you in the clinic, but not understanding. And respiratory palliative care for the very sick patient is extremely important. End-of-life care must be discussed much earlier than we do it. High proportion of these discussions were about 72 hours before the patient died, which is really not acceptable. And I would say these are the triggers to discuss it. Any of these should be the triggers when you're following up your patient to start a conversation on end-of-life care and advanced care planning for these patients. So to conclude, monitoring ILD starts with a secure diagnosis. Order your CT well, pulmonary function for monitoring and prognostication. Monitor your patients, look out for side effects, manage those side effects well, communicate all the time well, and we will have a lot of very sick patients coming to us in the near-term and long-term future. If we cannot cure them, we need to care for them well at least, and we got to get better at doing that. Modern medicine is a lot about medical care, unfortunately, rather than healthcare. And I hope all physicians here take that message that we are focused on the health of the patient, not just intervening with something or the other all the time. Thank you very much.
Thank you very much, Sujit. It was a very comprehensive talk and very enlightening talk. I would invite any question from the audience.
Sir, we have one question.
Sure, go on.
Yeah, and that is, how does CALIPER compare with the indigenous one designed in Bangalore called, I think, Predict or such similar name?
Predible. The name of that is Predible. I am not sure how it compares with that. There's no head-to-head study, but each center can develop their own softwares. CALIPER is the one that is being used in a lot of large studies. And that's why it's Mayo Clinic, developed in Mayo Clinic actually, and Inbio is the company that owns the system. So any CT radiologist can invest in any software. It is going to be the future because I think people will want to know much more about objectives. So even Predible could be equally good. I'm not sure. I haven't used it, but any good system, many hospitals, ILD clinics have developed their own software here. And we will need more data from Indian patients to actually validate these softwares. But for the time being, I would say CALIPER being validated by Mayo Clinic has a very large database in its AI algorithm.
Yes.
Well, sir, that was the only question I think we have. We can move on to our next speaker now.
Sujit, before we move on, I must compliment you on your very wonderful presentation and the brevity of information in the slides. You were absolutely to the point and brilliant. Thank you.
Thank you.
So I think we have Dr. Parthasarathy Bhattacharya who will be joining through his mobile. So
am I audible?
Yes, you're audible, but Dr.
Yeah, but I'm not visible, perhaps.
Yes, you're not visible.
I'm very sorry. I'm very sorry because of the technological glitch. I couldn't listen to the first speaker, but I listened to the wonderful deliberations, scholarly and insightful, of my two great friends, Dr. Nitin and Dr. Sujit. They're just unparalleled. Wonderful. I'm very sorry again that I cannot present my PowerPoint. I prepared one, but for the glitch, I couldn't access it, and Pawan has already dropped. Anyway, before the session is concluded, I will speak a few things about progressive fibrosing ILD. The topic was fibrosing ILD, when to treat, when not to treat. So you have to understand What is fibrosing ILD? I would say that after going through this fibrosing issue, there is a bit of confusion. We know that IPF is one disease which is predominantly fibrosing. The pathogenesis is from dysregulated fibrogenesis. And from the very beginning, it is a fibrosing disease, and the process is relentless, and it kills the patient very quickly within a span of few years. If you take the other varieties of ILD, non-IPF common DPLDs like chronic hypersensitivity, pneumonitis, sarcoidosis, drug-induced, etc., a part of them, a fraction of them, they also behave like fibrotic ILD. But this fibrotic ILD behavior is not progressive fibrotic ILD behavior. So there is a subtle difference between fibrotic and progressive fibrotic. If you go into the definition of DPLD, as such, the definition itself recognizes that there is an element of fibrosis. So all the DPLDs are fibrotic DPLDs. And of that, IPF is one which is predominantly fibrotic. So I say if we have to divide DPLD based on the fibrosis, we can say predominantly fibrotic and predominantly less fibrotic DPLD. So I'm meaning that certain DPLDs may behave differently, like say chronic HP. Some of them may be behaving as a less fibrotic DPLD. Some of them may be behaving as a fibrotic DPLD. And these fibrotic DPLD patients, once they cross a certain pace of worsening, they become progressive fibrotic DPLD. What is that boundary? The boundary is 10%, more than 10% decline on FVC in 1 year. For now, it is one part of the definition. The other part of the definition is that these patients have got increased symptoms. These patients have got poor quality of life, progressing, worsening of the quality of life, and they have got a higher risk of mortality. But all the other three, but the FVC is not measurable that easily. So I took FVC is a measurement. Once you say progressive, it is a longitudinal issue. So you have to measure at 2 points of time. And this gap is 1 year. So if you are theoretically strong, you have to measure with spirometry, at least at 1 year gap, and show that there is more than 10% decline. Why is this? Why name somebody progressive fibrosis when you know everyone is fibrotic? Someone is less fibrotic, someone is a little faster fibrotic. There is a reason. I'll come to it. But before that, I will tell you a little bit about the natural course of IPF. As you know, IPS is a dreadful disease. The 5-year survival rate is very poor. Some few patients, maybe less than 10%, survive more than 5 years. And if you see the course, there are 3 types of course. I'm sorry, I cannot project you, but I can describe the courses. The first variety has got a sharp decline, sharp, consistent loss of lung function, and they die out within 1 year. There's one variety which is relatively stable variety that continues for quite some time, and they gradually decline over years. But even then, their pace of decline is much faster than the other non-IPF ILDs. And the third variety may start with a stable decline, but there are sudden dips, and then again stabilization, then once again a dip. So if you take IPF together, and if you monitor the lung function longitudinally, a patient may appear stable, not losing more than 10% of FVC in 1 year time, but on next year, he may show a severe dip, even may 20% decline in FVC. So this measurement is not a very consistent parameter longitudinally over years to follow the course of IPF. But IPF as such is a progressive disease. As such, there are features of progressions which are very obvious, and we have radiological counterpart, radiological surrogate of this progression as honeycombing or UIP pattern. So radiological interpretation is very important. Sujit has told of gap score and other things. If you see the lung function parameter, the age, the sex, and other things which have been correlated to mortality, but none of them can predict the course of a particular IPF patient, whether this patient is going to have a slow progress or stepwise progress, certain stability, then sudden dip, or a consistent progressive, fast progress. So we have got a lot of limitations out here. We'll come to the non-IPF patients. The non-IPF patients, and as HP, chronic HP is the commonest in our locality in India. So let me take HP, for example. Some of the HP patients, they've got a slow indolent course. Some of the patients show a relatively faster course. And this relatively faster course patients, when they show more than 10% decline in FVC, they will be progressive fibrotic ILD. So IPF can be progressive fibrotic ILD. Non-IPF, some of them can be progressive fibrotic ILD. Now the question is, what is the pace of decline? Is this consistently same, or is there an acceleration on the pace of decline? The definition is not clear. They say persistent, sustained, self-sustained progression of the disease. Once there is self-sustenance of the progress, it doesn't mean acceleration, but there may be acceleration also. Maybe in the early part of the illness, their progress is slow. There may be multiple factors working. There may be some intrinsic factor, including genetic, metabolic, etc. There may be some extraneous factors that can influence the progress of a disease, and the disease might change its course from a slow, indolent, progressive development. It might suddenly turn faster development. So the patients will have progressive fibrotic ILD. Now, who are these patients? I looked at my data. I found that the average FVC of the patients who have been referred to me or have come to me being a naive patient or been referred is roughly 50%. So 50% of the forced vital capacity is lost. And in these patients, if you take a history of 2 years, 3 years, 4 years, you can just calculate that if the 50% lost in 3 years, it must be more than 10% of annual decline. So these are all progressive fibrotic DPLD. Now coming back to the IPF and non-IPF treatment. For IPF, we know it's a fibrotic phenotype, so there is no hesitation to recommend antifibrotic treatment like pirfenidone, like nintedanib. And there have been so many trials. Time and again, we discuss about the trials as a new drug being available in the market. Of late, there was plethora of webinars on nintedanib. And once it's nintedanib, then impulses, senses, these and that, a lot of trials. If you look at these trials, what is the baseline lung function? The baseline lung function is pretty good compared to our patients. The patients who were recruited, they had a baseline lung function of FVC around 78, 79%. And their DLCO, although lower, it was 47, 48%. And what was the change after 1 year of treatment? It is 207, 214, 94 ml, 114, 94 ml like that in impulses 1 and 2 trial. I don't remember the exact numbers. In census, it is less, maybe 90 or so, or 56 or something. But even that small bit of change, or even that small bit of savings in terms of FVC is important, because if that is continued, it will definitely improve the quality of life in long term. If you make a mathematical model, you can make it out. So people have recommended antifibrotic for IPF, once a diagnosis of IPF. Now in 2019, I came across a letter to the editor by Dr. Ganesh Raghu in Lancet Respiratory Medicine. Dr. Raghu, he proposed that like DPLD is a basket diagnosis. 300 entities are dumped into it. So he says IPF is also kind of basket entity where any end-stage disease is done. And it is not idiopathic pulmonary fibrosis. It is irreversible pulmonary fibrosis, where the fibrosis is irreversible. So whatever be the etiology, if the fibrosis is fast, if the fibrosis is obvious, if the fibrosis is very well apparent, why not give treatment with antifibrotic? And it's been found the mechanism of fibrosis is almost similar across the causes. So now people are telling that you treat these non-IPF patients with features of fibrosis or progressive fibrosis with antifibrotic drugs. As such, we are accustomed to give them steroid and or plus minus anti-immunosuppressants. But now it's a second line indication that you add antifibrotic to them if they are of progressive fibrotic variety. So now it is clear to our mind that all IPF antifibrotic, all non-IPF with progressive fibrotic element that we can take up from the history. Although it's not written in the literature that history to be taken, but I, for practical purpose, think that this is very relevant in our real world, where we find patients already been late. So we can take history in 2 or 3 years. If we find that FVC has gone down to 40%, 50% like that, it must be very fast, decline of FVC. And these patients must qualify for add-on antifibrotic on top of steroid plus minus immunosuppressants, if whatever be the diagnosis. Maybe it's a sarcoidosis, maybe it's a hypersensitivity pneumonitis, or a CTD-ILD. Once I was going through yesterday, I had a thought in my mind, and I'll finish with this thought. This thought is that, see, all ILDs are fibrotic. Be a little less fibrotic, be more fibrotic. So what is our purpose? To stop the progress. So the research today must focus on early diseases. We do not know which, say, for example, if you take again chronic HP in consideration, we do not know which one of them will progress to fibrosis and which one not. We must look for factors that can influence the course. That should be our research. We must look for factors that can be used as biomarkers. They may be radiological indicators. So we must be very thorough on HRCT. And after listening to Sujit, in fact, this is an impression of my mind from the beginning that radiological markers are going to be the game changer in future. Metabolic markers, other molecular markers, I do not know. I'm not very comfortable with them. They must be very costly, but HRCT is something, and with the artificial intelligence being applied to it, they may be working as a very good marker for early diagnosis and early prediction of the rapidly growing or rapidly fibrotic variety of non-IPF ILDs. So we must have focused our research on that front. And before I end, I would say that since I work in the grassroots level, I don't have access to all those things. And I always feel that let us see something differently. So we did sort of semi-quantitative marking of different kinds of pathologies, of different kinds of radiological abnormalities in our DPLD patients. And we have already one manuscript been communicated to a journal where
I think we have
there are three
lost.
features that will be affecting DPLD: honeycombing, traction bronchiectasis, and fine reticulations. And what we took for non-fibrotic or less fibrotic features are the ground glass opacities, mosaic appearance, organizations, and some pleural-based densities. So I'm sorry I couldn't present it, but from that, only yesterday, I looked for a new thing. I took 19 patients of fibrotic DPLD, and then I looked at their treatment. I found that all these 19 patients were given pirfenidone by me. Just to see a control on non-fibrotic side, I took 32 patients and I looked at their treatment. I found that none of them was given pirfenidone. I looked at the scoring. It was so distinctly different. You would be very impressed to see that the scoring for traction bronchiectasis, honeycombing, and reticulation. Reticulation is not that great difference, but the other two are grossly different. But if you take ground glass opacity, is far higher in the non-fibrotic category, maybe far higher. And organization is definitely, is a predominant feature of non-fibrotic category. By that, we can divide our patients, fibrotic versus non-fibrotic. And if we look at our DPLD, one of my thought is that we must simplify the whole thing. We must look from a very simple viewpoint. Is it treatable or not? If it is treatable, what is the treatment? Is it steroid or is it antifibrotic? So from that point of view, I decided that it is worthwhile to look at the radiological classification of DPLD as fibrotic vis-a-vis non-fibrotic. And this kind of approach might be very helpful for us in future. So with this all, I thank you very much for listening to me. I am very sorry. I'm feeling very sad, but whatever input I had, I couldn't place you properly. I hope you have enjoyed the wonderful deliberations of Sujit, Nitin, and Arindam. DPLD is a fascinating area and it's going to grow in this country. I hope all of us be involved in some or other kind of small bit of research, whatever be it. And I hope we tie ourselves, hold our hands together so that we have got a big power. At least we have got a big bulk in any subject, in any disease in this country. It is very unfortunate that still we are not together. If we are together, even we cannot do much molecular stuff. We can do a lot of clinical stuff where people will be even forced to salute us. Thank you once again. Thank you very much. I hope you'll continue to join our PULMOCON modules. Next week, we have got a wonderful lecture by Professor Padmanabhan Balaram. Actually, he was supposed to talk in the first module of PULMOCON. This is Professor S.N. Dey Memorial Oration. As you all know, Professor S.N. Dey is an unsung hero in this country. He was the innovator of cholera toxin. With the very basic things, he discovered this great thing. And he was nominated for Nobel Prize from USA many times. But he died absolutely unrecognized in 80s in this city. This is unfortunate and it's a matter of shame for us. So we started Professor S.N. Dey Memorial Oration 13 years back. And this time, Dr. Padmanabhan, he's a retired director of the Indian Institute of Science, Bangalore. And he happened to be the person who made Dr. S.N. Dey, visible to our population. It's a resurgence of S.N. Dey through Dr. Padmanabhan. He'll be talking, how did I discover Dr. S.N. Dey? So I will request you all to join PULMOCON. I'll also request you all to register with our website, with our with us, www.pulmocareindia.org. We will send you all the information, so whatever small bit of academics we are doing, and we will invite you for all meetings. For now, it's all free. We have few more modules on next few Sundays of PULMOCON. I wish to welcome you all in PULMOCON. Thank you very much. And I just pass over it to my respected chairman.
Thank you,
Sir,
right.
Sir, we have two questions.
Yeah.
Okay, I will read it out. First question is, what is the way to provide palliative care for patient suffering with LVDD with COPD and facing coma attacks? In reference to your paper published in COPD Journal in 2009, you referred to myocardial ischemia diagnostics play an important role in improving the quality of life and sustainability. Can you elaborate it?
Is it a question to me? Yes. So can you read the question once again?
What is the way to provide palliative care for patients suffering with LVDD, with COPD and facing coma attacks? In reference to your paper published in COPD Journal in 2009.
So it is LVDD, COPD, coma. So there are 3 chapters in this patient. One is a coma, other is a LVDD, and the third is a COPD. Now you have to see which element is more, disturbing for you at any point of time, at a particular point of time. So, and you have to take care of all 3. Now this LVDD, I take it as a diastolic heart failure. So there is a diastolic heart failure, there is COPD, and there is coma. Now it depends. Suppose you are going to treat LVDD and COPD, and you have to give importance to both. You have to take care that the patient is not overburdened with fluid. You have to see that his pulse rate doesn't shoot up for any reason. And you have to see that why the left ventricle is stiff. This stiffening of the left ventricle that leads to left ventricular diastolic dysfunction are usually secondary to certain reasons. Some of them can be modifiable. Some of them can be treatable. And it has been found that LVDD without any obvious cause is in 60% related to silent myocardial ischemia. And that too is my publication in 2012. So you have to take care of that. You have to take care of COPD adequately, and you have to definitely take care of coma and the treatment related to it. So you have to decide which one needs how much of stress. All 3 should be treated simultaneously. But you have to decide your stress on individual component according to its severity. Coma is definitely very important. You have to treat it according to the cause. COPD, you have to treat. COPD is not going to kill the patient immediately, but if the comatose patient is not taken care of, he might aspirate and pass away. So it depends. I cannot have a straight answer. It will vary from case to case.
Okay, sir, we have one more question. And that is, what is the ideal therapy for early respiratory bronchiolitis ILD, looking into the prevalence of tobacco smoking in India?
Early respiratory bronchiolitis ILD. So if there is a tobacco smoking related bronchiolitis, smoking cessation is the best answer. And if it is not tobacco smoking related, then it needs a lot of other things, issues to be discussed. So if the patient is a smoker, at the first job in early DPLD with bronchiolitis, early bronchiolitis, you must stop smoking. We have our learned chairpersons also. So let them also contribute to this answer. Dr. Angshuman sir, would you take care of the mic and hello? Is Angshuman present?
Hello.
Huh? Hello, Dr. Mukherjee. Hello.
I think Dr. Mukherjee has muted himself.
Okay. So, yeah. Suranjan? If you have any comments, sir.
Can I go through the question once more?
So should I read the questions
yes.
to you? Okay.
Can you read the question once more?
Okay. What is the ideal therapy for early respiratory bronchiolitis ILD, looking into the prevalence of tobacco smoking in India?
I mean, as far as my knowledge goes, I think if it's a sort of early our build, then probably the best thing is to stop smoking. At this moment, I'm not aware of any pharmacological intervention to go into to treat our build. I mean, that's my knowledge about our build as well. I don't know whether Dr. Angshuman wants to add anything.
No, I completely agree with you. I was actually not being able to interject before. So Arbil, the only therapy that we know of is cessation of smoking. But if you ask for the prevalence, I don't think there are any data on prevalence in our country.
If the patient is non-smoker, Dr. Mukherjee, then perhaps this patient requires, evaluations for bronchiolitis and treatment.
But Arbil classically has been associated with smoking. So
right, sir.
In fact, if I can add, Partha.
Yeah.
I think it's a very important reason to screen all smokers with CT. Not just for our build, but for smoking-related interstitial fibrosis, which has various patterns, DIP. You could pick up a lung cancer nodule. So I think screening CT scans in smokers, especially, I would look at a cutoff of 10 pack years, maybe anything more than that you should screen. So it's advice for heavier smokers, but we pick up things that we don't realize that.
True. Absolutely. I fully agree with you.
And probably a better incentive to quit smoking if we pick up something.
Sure.
So one interesting food for thought. I mean, looking at the antifibrotic therapies,
right,
and looking at the three sort of phenotypes of IPF, I mean, just focusing on their disease progression.
Right.
You all know that there are three sort of broad phenotypes of progression. One is a rapid deterioration, one is a slow deterioration. Now, in the studies, on all the studies on antifibrotic therapy, has that sort of ever been clarified or mentioned that to which phenotype that this particular patient belongs? I don't think so, because it's absolutely difficult to say from the onset of the disease that how this particular patient is going to progress. Now, when we're assessing the effects of the antifibrotic, we don't know how much effect it has got on each of these phenotypes, whether it works preferentially on the slower progressing phenotype or the rapidly progressing phenotype. We don't know. We know it slows the progression, but for a particular patient, actually we don't know which phenotype it has originally belonged to.
Right.
Yeah, it's a very good question. In fact, yesterday I was thinking, what is the relative frequency of these three different phenotypes? So I looked at literature. I found that the relatively stable patients are roughly 11-12%, and the rapidly progressing one is 15 to 20%. The in between is the biggest chunk. So if you take these two extreme, nullifying each other, almost same in, or maybe the almost same. So the intermediate type that having intermediate in between decline of lung function, they form the bulk, and you have to take that course as a natural history of almost all of IPF. So from that way, I do not know whether they look for anything. We don't have any instrument.
I think no one knows at this point.
No, we don't have any instrument. There's no biomarker to understand who is a rapidly progressing IPF, who is a relatively slowly progressing IPF. We don't have any biomarker, at least to my knowledge right now. So I cannot answer that question. Sujit, anything you can add to?
Yeah, the only thing, Partha, I agree, it's a very good question. We know that if we define progressive fibrosing ILD, we would offer it to anyone who progresses based on the inbuilt criteria. The only thing that's not in the inbuilt criteria is DLCO, which someone has now proposed to add to the criteria for progressive fibrosing ILD. But it's hard to say which, and so someone would say, look, I think even say 5% progression on CT without any other progression, I want to start an antifibrotic. Someone else may say, no, we go strictly by the inbuilt criteria, which is 24 months. That gives a lot of time actually for a patient to progress. So it's really hard. But one thing I would say there's in CTD ILD, Suranjan, their scleroderma stands out, I think.
Yeah, I think that's the difference.
Yeah, so that scleroderma, any fibrosis should be on an antifibrotic. I think the data is very clear that even if there's a little bit of fibrosis, they're going to progress faster. Mortality is higher than no ILD.
Correct.
A question for Nitin, please. Nitin, I know you're known as one of the high volume centers doing lung biopsies. So how are you changing your mode from transbronchial to thoracoscopic biopsies to cryobiopsies now? Are you only on to cryobiopsies, or how do you select?
In fact, the cryobiopsies are still a very small in number. We have just performed about 3 in the last 1 year. And in fact, last 1 year, as I told you, it has been a big black hole. So, whatever happened is in the first 2 or 3 months of it. And then it is all, after March. So, but if you really ask me, even today, with the kind of cryopro pricing, very frankly, you have to think of pricing in this country as an important issue. VATS biopsies are afforded by a very small percentage of my patients, very frankly. Though I have access to VATS, and we have landed up doing something like 5 VATS biopsies in the last 15 years. Thoracoscopic lung biopsies is the cheapest in that sense. Of course, transbronchial lung biopsy is the cheapest. It doesn't cost anything more than an ordinary bronchoscopy. But then transbronchial lung biopsy has only limited applications in the terms of sarcoids or hypersensitivity, some organizing pneumonia. So it's not going to yield a majority of them are not going to be happy with that. If you are looking for a big tissue, then cryobiopsy versus thoracoscopic lung biopsy is what 2 options I have in my and what I find is that, with the kind of new disposable probing system which they have come up with, the cryobiopsy's cost has gone way higher than my thoracoscopic lung biopsies, and I get nearly triple the size of biopsies. My total biopsy size is 2 centimeter by 2 centimeter, which is half of what a surgical biopsy is, but nearly double of what a typical cryobiopsy collective specimen would be. So I'm able to give, plus I am able to give it from all 3 lobes. So what I find in my practice relevant is, even today, if I really want a surgical equivalent biopsy, then I will go for a medical thoracoscopic lung biopsy or a VATS biopsy if the patient is needing VATS. Particularly if I have a cystic disease, I'm not really going to be sure about controlling the air leaks and such things, I would opt for a VATS biopsy. Otherwise, I'll opt for any diffuse parenchymal lung disease. Otherwise, by choice, if I require a surgical biopsy, I'll do a medical thoracoscopic lung biopsy. It has been, the yield has been as high as 99%, because our pathologists have never said, this is inadequate sample, or I can't comment on this, or that has never happened. because of the size of the biopsy being reasonably good and
What?
and a representative sample. So sometimes you get a normal sample from the upper lobe and a middle lobe and the lower lobes having the disease. So that has happened a number of times.
By a medical thoracoscopic lung biopsy, you mean a rigid medical thoracoscopy?
Rigid medical thoracoscopy. It can't be done by a small fiber optic. You need a big size cup forceps. You need a cautery current of 40 watts. So you need a surgical like setup, but it is done under conscious sedation and local anesthesia plus conscious sedation. So it is managed with much less invasion. We do 2 ports, but even with 2 ports, there is a drain in there for about 2 days, and that's it. So very frankly, I think, if you see our Indian practice scenario, medical thoracoscopic lung biopsy is not a bad idea from the point of view of actually reaching a proper diagnosis in a large percentage of your patients. Of course, once in a while, I'll resort to cryobiopsy when I know that the pathology is central enough and I can access it better. But if I think the disease is peripheral, I would rather go for a thoracoscopic lung biopsy, either VATS or medical thoracoscopy.
And what about air leaks, persistent air leaks after medical thoracoscopy?
We don't have that problem. I can tell you that all the data that we have is 10% air leaks going on up to 7 days. 10% of the people, 90% people stop on the table by itself, and out of 142 people have leaked, one for 15 days, which was the high density polyethylene related fibrosis, which was done for a medical legal purpose of getting compensation for him. And the one which has leaked longest, 26 days, was a person who did not even have, it was a UIP on histopathology, did not even have macrocystic honeycombing to detect. There was no emphysema, nothing whatsoever. So we are not able to correlate the air leaks with the kind of a pathology that we are seeing on the CT scan or otherwise. But air leaks is the only problem. Never encountered any bleeding episodes which are important. I have never transfused somebody for lung biopsy ever at all, up to 100 out of 140, not even one. The air leaks is an issue, and air leaks will remain an issue because you are actually biopsying a collapsed lung. So and for that matter, whenever we have done VATS, we have had air leaks which are little longer than 7 days, more often than not. So when we do VATS, see, why are we getting air leaks? Not because the VATS is a bad surgery. In fact, it's the most fabulous surgery because you are stapling the entire thing, but you are stapling the collapsed lung. And you are not stapling an inflated lung. So whatever you are doing is going to inflate, and eventually there will be a loose end at both extremes of it. So there is going to be whatever number of staples you use, still there will be a air leak. Whatever you do with medical thoracoscopy, howsoever cautery current you are applying, howsoever good coagulation, on the spot, you don't see air leaks ever at all. They happen on 2nd or 3rd day if they happen. And it's unpredictable. So I think, of course, you choose your patients well. I don't biopsy a cystic lung, preferably with a medical thoracoscopic lung biopsy. I'll take tabular patients. Of course, you are today not doing it in hypoxic patients anymore. And of course, the biopsies in general are reducing. If you really see that overall trend, it is more towards less and less biopsies, more radiologically oriented diagnostics, more multidisciplinary discussion early on. And plus, we have a collective experience of 140 biopsies to aid our thinking. Plus, the hypersensitivity pneumonia often gets sorted out by a cryobiopsy very well. So if you do if your TBLB is not helping, a cryobiopsy will help in hypersensitivity, sarcoids. Most of the central peribronchovascular diseases would be sorted out by that. So I think, again, so that will reduce the number of surgical or even the semi-surgical, which I do. So those numbers are dwindling, actually, if you really see. Over the last 10 years or so, it has gone down from, say, 12 to 15 per year to around 6 or 7 per year. That is the number that we are having now. Last year, I have not done any. Absolutely. 2020 has been a blind territory.
Well, the problem, Nitin, is, if you are taking 2 or 3 samples,
six samples. I take up to 6 samples.
6 samples. Now, each time, the cost of the staples goes up.
Yeah, absolutely. So see, a stapler can't do 6 biopsies. Stapler can maximum do 2 biopsies.
2, yes.
Whereas medical thoracoscopic biopsy, I can do 6 samples without no extra cost whatsoever at all. I am not stapling. I'm not stapling at all.
So he is using a cautery with a
coagulation current of around 40 watts. You hold the tissue, you start pulling it, and apply the cautery current. It is for about 5 to 10 seconds at the most. And with that cautery current, the tissue, once it becomes loose, the outside of it's a cupped biopsy forceps. So outside of it may be coagulated, but your core part is intact. And we have never seen a pathologist saying that this is a dead tissue or this is a burnt tissue. That kind of stuff we never get. And we have got this cross-reported by people like Dr. Andrichur. So, I mean, they have never said that, what you are giving me is artifacts or something like that. We also learned the technique of inflating the samples. So, because when you take them, you are actually holding them tight in a cup forceps. Once you take them out, we inflate them with formalin. So if you do a formalin inflation, they take their normal size. So they become 3 or 4 times larger in actual size. So when we actually collect a sample, it is maybe say 1 centimeter, 1 centimeter. With inflation, it becomes 2 centimeter by 2 centimeter.
Okay.
This is innovative, not widely practiced. So unfortunately, my study is not replicated anywhere else. But at the same time, it's not a bad idea to do it at all. We have never found it, risky. 5 of my patients have been lawyers and nobody has sued me till date. So I don't think I had medical legal issues on this. They understand the logic of doing it. They understand the risk associated with. We have explained to them that the air leak is not in anybody's control, whether it is a VATS or this, either ways.
Yes. Thank you very much, Nitin, for that experience speaking behind that answer. So that's very good, very good.
Great session.
Okay. So shall we conclude the session?
Sir, we have one more question with us. And should I read it out for you?
Yes.
Okay. So the question is, what is the indication of steroids in ILD?
I think it is yours.
It needs another session.
Yeah.
It needs another session.
I
We'll
think,
make one session on treatment of BPL.
I think, Partha, if I have to give any message on that question is, please don't give steroids indefinitely. Maybe Nitin will agree on that.
Absolutely.
Whether it's chronic HP or CTD ILD, 4 to 6 months of steroid should be enough in most patients, and you need to move on with an alternative immunosuppressant. Maybe that's a message that could go across.
Yeah, I absolutely agree to Sujit. We start steroid, but we taper off.
That's
and
right.
within 3 months, I come down to almost physiological level.
We see too many patients.
But we continue the immunosuppressant one for a longer duration.
That's right.
And there are many HP centers across the world who are now first up offering something like mycophenolate rather than steroids at all. So there are people who are So there are thought processes already in the pipeline, and I think things like mycophenolate may pick up as future prospective therapies for, say, chronic HP directly rather than giving steroids at all.
I think the reason to start steroids should be if you're hoping to gain some lung function. I mean, if you're going to gain something, try it out for about 8 weeks, repeat your vital capacity. And if that has improved, you've gained something, now you got to get down to the lowest possible dose or omit by 4 to 6 months with an alternative immunosuppressant.
I think I completely agree with Sujit. I think what we practice is about 6 weeks of steroids and then repeat the physiology and the radiology, and then if it's responsive, then taper down steroids and add on immunosuppressants.
Yeah, most important thing I think is to remove the patient from the environment. If that is possible, your treatment becomes easy.
And nothing like that. But most of the HP that we deal with is often so badly classified on the etiology front, so poorly that it doesn't. I mean, all the data that we have is so ridiculously poor on this. Even the pigeons, we see so many pigeons, but the pigeon sensitization is not very well reproducible, even on the laboratory. So I think that is the limiting factor, that we are not able to do the challenge in the correct way, the aero challenge all over again, and then reproducing it and then removing it. So once that part is missing in most of the chronic HPs that we deal with. If we know the etiology, removing is the best idea. I think many people, we see that in wheat bhatti. We have in Western Maharashtra, we have the wheat bhattis where the wheats are prepared, the bricks are prepared. So the brick kilns, they use the molasses which comes from the sugarcane industry. So that is used as the heating material. and people get sensitized to the fungus in that. And the moment you move that person away from it, the lung function normalizes very rapidly. So in fact, that is one entity where we see the removal from the offending agent is a classical therapy, and it works brilliantly. But when you don't know, when a city dweller, pigeons plus
Absolutely.
minus and nothing else, and then you have a chronic HP, it is very difficult to find the antigen.
I think I'd probably add one more thing, that probably sarcoid. Sarcoid is one disease where it's a little hard to get the steroid off in a certain number of patients. So
True.
where you have very few alternatives like methotrexate and maybe azathioprine, but they don't work so well really in pulmonary sarcoid. So there you're sometimes left with 5 milligrams or 7.5 a day.
Especially those relapsing again and again.
That's right. That's right. That's the one disease maybe you have to go on.
Yeah, I agree.
So I think we come to the end of this session. There are no further questions, and with thanks to all of the speakers, we would like to say good night to all of you.
Good night. Good night.
Thank you very much, Sujit. You remember my track record when we got introduced in Kanpur, NAPCON? My slides were not working. Today I'm reminded the same story again.
Partho, you don't need slides. I mean, you